Good afternoon. My name is Dr. James Rippey, and it is my pleasure to be the moderator of today's webinar, which will be delivered by Marion Franz. Before we start the webinar, however, I would like to turn the webinar over to Amy Stocknick, who will give you some of the logistics.
Thank you, Dr. Rippey. The CEUs, a link to obtain your personalized continuing education credit certificate will be emailed within 2 days. A recording of today's webinar, slides, and summary PowerPoint will be available to download as a PDF within 2 days at our website, and the presenter will answer questions at the end of this webinar. Please submit your questions by using the chat dialog box on your computer screen. Thank you, Dr. B.
Today's webinar is part of a series of webinars, the NutriBite webinar series, which is sponsored by the Conagra Food Science Institute. The Conagra Food Science Institute has a mission of promoting dietary and related choices affecting wellness by linking evidence-based understanding with practice. Today's faculty, as I mentioned, is Marion Franz. I will be introducing Marion formally in just a few moments. Because this is a CEU activity from the Academy of Nutrition and Dietetics, we list that specific learning objectives, and you can read them on this slide. It is now my pleasure to introduce Marion Franz. Let me start by saying Marion Franz is a nutrition health consultant with Nutrition Concepts by Franz Incorporated. For over 20 years, she was the Director of Nutrition and Health Professional Education at the International Diabetes Center, Minneapolis, Minnesota. Her master's degree in nutrition is from the University of Minnesota, and she is a registered dietitian and certified diabetes educator. She has authored over 200 articles, books, booklets, and book chapters on diabetes, nutrition, and exercise, and lectures frequently in the United States and internationally. I should also mention that the superb chapter that Ms. Franz did for the second edition of my Lifestyle Medicine textbook is available on our website as a PDF for download. It is now my pleasure to introduce Marion Franz.
Thank you very much, and it's really an honor to present this webinar on the lifestyle approaches to the prevention and treatment of diabetes. Perhaps you've heard or read the objectives, but perhaps one of the most important questions all of us need to ask as clinicians and educators are our interventions effective? So we begin by looking at the evidence for the effectiveness of nutrition therapy. I assume many of you hopefully are familiar with the studies that have been done implementing nutrition therapy in individuals with pre-diabetes, showing that nutrition therapy, basically a reduced energy intake, low-fat diet along with physical activity, decreased the risk of type 2 diabetes by 58%. And in the follow-up studies of individuals who maintained the same changes they had made during the trial, their risk reduction was continued for up to 14 years. But if you look at individuals who then have diabetes, the evidence suggests that nutrition therapy, on average, can lower A1Cs by about 1% to 2%, depending upon the type of diabetes, how long individuals have had it, and their level of glycemic control. We also have evidence for the benefit of nutrition therapy on lipids, particularly LDL cholesterol, blood pressure. But I think what also is extremely as important for all of us is to know when should we evaluate outcomes. And the research has shown that the outcomes of nutrition therapy interventions will be known by 6 weeks, clearly by 3 months. And if the goals have not been met, then we need to look at perhaps some changes in the overall diabetes management picture. So let me just share a couple slides with you that document the effectiveness. This is a slide from the United Kingdom Prospective Diabetes Study done in Great Britain. And in this study, individuals were diagnosed with a hemoglobin A1C of And after 3 months of intervention with the dietitians in Great Britain, they were randomized into the study arms with an A1C of 7%, so a 2% lowering. But what is also interesting to look at is the conventional group, which is primarily controlled by diet. And what you'll see is if you follow it out for 4 years or so, their A1Cs are still under about 7.5%. So the durability of the nutrition intervention. The next slide is another interesting study, also done in Great Britain. And here individuals were also newly diagnosed with type 2 diabetes, but here their baseline A1C was about 6.7%. And they were randomized into usual care or into intensive nutrition therapy with or without physical activity. And at 6 months and maintained to 12 months, there was no improvement in usual care, but there was a statistically significant improvement in the nutrition therapy group. You can see 0.3%. And this occurred even with the use of fewer diabetes drugs. And in this study, the addition of physical activity provided no added benefit. But you can see in the first study, when individuals started with an A1C of 9, you had a 2% drop. Here you have a little smaller drop, both very statistically significant. This study is interesting because it was done in New Zealand, and here individuals had a longer average duration of diabetes of 9 years, and they were considered to be under less than optimal glycemic control. And so they were randomized to control group or into intensive nutrition therapy, 6 sessions with a dietitian in New Zealand, and again, a statistically significant drop in A1C in the nutrition therapy arm versus a control, 0.4%. And the researcher may note that this was comparable to adding a third drug to their program, and that it was more cost effective. If we look then at type 2 diabetes, a common intervention there has been flexible intensive insulin therapy, which involved using insulin to carbohydrate ratios. The first study done looking at this was called Dose Adjusted for Normal Eating, and individuals were taught to adjust their insulin dose based on their planned carbohydrate intake. And in the group that did this compared to the control group, which continued in their previous pattern of doing things, A1C was lowered by 1%, with no more increase in severe hypoglycemia, which had sort of been predicted, despite the fact that they needed to do more blood glucose monitoring and take additional insulin injection. The participants reported an improvement in their quality of life. And the A1C improved without the total insulin dose remained the same. There have been follow-up studies supporting and showing the continued improvement, and this program has also been studied in other European countries, also showing improvement. One of the concerns was that they said some thought was that if you gave people with diabetes all this freedom, they might eat excessively or unhealthy. And they also looked at that and found that that did not happen. So there are a number of studies. I've just shown you a few examples documenting the effectiveness of nutrition therapy. But if we ask the question, what type of nutrition therapy interventions are effective, what we find is that there are a variety that are. Some studies use reduced energy or fat intake, carbohydrate counting, simplified meal plans, healthy food choices, exchanges, insulin to carbohydrate ratios, physical activity, and behavioral strategies. But if we look to see, is there some sort of theme that unites some of this for the different types of diabetes? I think what we basically see that in type 2 diabetes, what was important was that the individuals had a reduced energy intake. And in type 1, it was clearly matching insulin to carbohydrate intake. And also what was required is that there needed to be a number of individual or group sessions, and certainly follow-up and support needed to be provided. So if we move on to type 2 diabetes, and I think we're all familiar with that, what we have clearly learned is that type 2 diabetes is a progressive disease. And although it may begin with insulin resistance, as long as an individual's pancreas can make adequate insulin, the green line at the bottom of the graph, blood glucose levels remain normal. It's not until individuals become insulin deficient that they develop type 2 diabetes. And you can see the first defect is usually in postprandial glycemia, and then the second is in the fasting level. Overnight, the liver releases excessive amounts of glucose. But if you follow the green line at the bottom, it's been reported that if individuals with diabetes live long enough, which we certainly hope they will, eventually they will all become insulin deficient to the point where they'll need supplementary insulin. So, just as we have said that the disease is progressive, and we know that medical management is progressive, so too is our nutrition therapy. And so if we look at, we have our interventions when people have pre-diabetes are different from our interventions once the diagnosis of diabetes is made. And what we'll see is that what's important when individuals have pre-diabetes is a reduced energy intake leading to modest weight loss and physical activity. But as the disease progresses, our focus changes to focusing on helping individuals achieve glucose, lipid, and blood pressure goals. So let's spend a minute looking at some of the dilemmas of weight loss and diabetes. And if there's one saying I wish we could get rid of, it's diet fails. Because a diet works great when it's used appropriately. As you saw on the first slide, the previous slide, what is failing is the beta cells of the pancreas. And what we find is that modest weight loss is most effective during periods when individuals are most insulin resistant. And we said that was in pre-diabetes and generally early in the course of the disease. But as we mentioned, as the insulin deficiency becomes more of a factor, we focus on helping achieve glucose, lipid, and blood pressure goals, and again, making sure we know when to evaluate outcomes. Let's spend just a minute looking at what we know about weight management. What's clear is that at 6 months, on average, individuals lose about 5 to 10% of their starting weight. And that's regardless of what the starting weight was. And then regardless of the intervention, plateaus and regain of weight loss often occur. And the reason for this is that compensatory mechanisms, which we'll speak about in just a minute, take over, which protect the body against weight loss. It's clear our bodies do not want to be starved. But what I also hope to convince you of, that if treatment is continued, modest weight loss can be maintained. So this is a systematic review that we did, looking at year-long weight loss intervention studies that were a minimum of 1 year. And you can see there were 80 studies with over 26,000 subjects. And the top line, what we did then was to pool the different interventions to see what the weight loss was from each intervention. And the top line is what happens when you just tell people to go home and lose weight. Well, as someone pointed out, at least they didn't gain. The yellow line is when people try to just lose weight by exercise. The third line is when the emphasis is just on the diet. Although we paid lip service to physical activity, the emphasis here was on the diet. The lines in the middle then are, the green line is diet plus physical activity. And here there were specific recommendations for physical activity, and they were measured along with the weight loss diet interventions. Also, meal replacements, orlistat and sibutramine. And then the bottom line is the very low-calorie diets where they lost a lot of weight quickly and gained it back. Now, it's interesting to note, you'll see that regardless of the intervention, at about 6 months, people did hit a plateau. And if we look to see how much weight they lost, you'll notice they lost about 8 kilograms. Most of these individuals weigh between 95 to 105 kilograms, so that's about an 8% weight loss. Now, the question I'm often asked is, well, could you re-intervene when people hit the plateau and cause them to lose weight again? There's only one study in the literature that's really tried to do that, and what they did when people started to regain is they had a very intensive intervention, including meal replacements and sibutramine. What they found is they could bring people back to the plateau, but they did not lower them below the plateau. So I can find no evidence in the literature that once people hit the plateau, they go much below that. Now, I always point out to people, though, that this is a bell-shaped curve, which means that these are the people in the middle of the bell-shaped curve. There are always people who lose more, obviously. They're the people you remember. You read about them in the magazines or you hear about them on television. Unfortunately, there are always people at the other end of the bell-shaped curve who lose no weight. But the people in these trials tended to be more middle-aged, kind of the people that we often see in clinical practice. Now, what have we learned about why weight loss is difficult? Well, we know there is a genetic factor, but as often pointed out, our genes haven't changed very much. But what research, I think, is helping us understand is how our weight is tightly regulated by neurohormonal and metabolic factors. And you can see that as people lose weight, there are many adaptations that occur in a whole number of body hormones. And what this change in these hormones does then is to send a message up to the hypothalamus that says the fat cells are emptying, eat. And what happens then is appetite is stimulated and weight gain often occurs. And studies have shown that many of these changes in these hormones remain even 1 year after the initial weight loss. Secondly, studies have shown that weight loss also results in adaptive thermogenesis. And what that means is there's a decrease in the resting metabolic rate, which is about 80% of our caloric requirement. So not as many calories are required. And again, studies have shown that that adaptation has continued for up to a year. So I think all of this helps us to understand why weight loss is difficult for so many people. But you'll notice that on the slide, the weight loss was about 8%, which may not seem like a great deal. But I think a very important message for all of us as clinicians and health professionals is to educate the public as to the importance of the benefits from modest weight loss. It is this type of weight loss that prevents or delays type 2 diabetes. This is the type of weight loss that improves blood pressure, decreases circulatory inflammatory markers, and may or may not improve lipids. This study is from the Diabetes Prevention Study, and many of you may be familiar with it. But you'll see the red line at the bottom, which was the intensive lifestyle intervention. And you'll see that at 6 months, they had lost about 7% of their weight and hit a plateau and gradually began to regain. But the good news, it was this type of weight loss that reduced their risk of developing diabetes by 58%. and you can see the metformin is the middle group and the top group is a placebo. So we need to educate the public as to the importance of modest weight loss for the reduction in the risk of developing type 2 diabetes. Now, the question often comes up, what type of diet works best for weight loss? And this is perhaps one of the best weight loss studies that's been done. There were over 811 adults who were enrolled in the study, 80% completers, and they were randomized to either a high or low protein, high or low fat, or high or low carbohydrate diet. And what they showed is that at the end of 6 months, each group lost an average of 6 kilograms or 7%, as we showed you earlier, and began to regain after 12 months. But at the end of 2 years, they had maintained an average weight loss of 4 kilograms. So they asked individuals about satiety and hunger and satisfaction with the diet, and they were similar, regardless of the type of diet they were on, as well as was their attendance at group sessions was similar. And all of the diets equally improved lipid-related risks, fasting insulin, and blood pressure levels. And so the conclusion was from the study was what matters is the energy intake, calories, not macronutrients. What also was important was that individuals did best who attended the most sessions. So multiple encounters were needed. And in an accompanying editorial, the editorial writer concluded any type of weight loss diet taught with enthusiasm and persistence can be effective. He also commented that thus even these highly motivated, intelligent participants, because they were selected to be in the study, who were coached by experts, professionals, could not achieve the weight losses needed to reverse the obesity epidemic. But we need to point out that it did. This is a type of weight loss that has health benefits. So what have we learned about weight loss? Well, I'm always amazed at all the diet books that are written without a single trial being done to show that they are effective. And healthcare professionals wouldn't prescribe drugs that have been shown to be effective, yet they will write and recommend diet books. It's really reduced energy intake and support that's needed, and we need to, again, as I said, emphasize the importance of the benefits of modest weight loss. What about weight loss studies in people with type 2 diabetes? And this is a systematic review that we've just completed. Here, the studies were in individuals with type 2 diabetes. The study had to be 1 year in duration and a 70% completion rate. There were 11 studies, that would be 22 arms, and 8 of the studies compared weight loss interventions, and 3 compared weight loss interventions to usual care or control. So there were 19 weight loss interventions. And we looked at weight, A1C, lipids, and blood pressure. What we found is that at 1 year, weight losses in these studies range from about 1.9 kilograms to 8.4. But the majority of the interventions, remember we said there were 19, in 17 of them, the weight loss was 1.9 to 4.8 kilograms. Now remember we said in the people without diabetes that their average weight loss was closer to 7 kilograms. So it does appear harder for people with diabetes to lose weight. The two interventions that had a greater weight loss were a Mediterranean-style diet, which is done in individuals who are newly diagnosed, and then the intensive lifestyle intervention, which is part of the Look Ahead trial, which is a very, very intensive intervention. And there you can see the weight loss intervention. And the lowest weight loss was in a weight loss intervention that promoted a low-carb diet. So here are the weight change outcomes in these studies in people with diabetes. The bottom line is the look-ahead intensive lifestyle intervention. The second bottom line is the Mediterranean. And both of these two also emphasized and collected data on physical activity. And then you can see all the other interventions with less than a 5-kilogram weight loss. So if we looked at the effect of these interventions at 1 year on A1C, what we found is that 8 of the 19 reported improvements in A1C, but 11 reported no improvement in A1C at 1 year. The majority reported non-significant changes in lipids. The biggest improvement was in HDL, and then about half reported improvement in blood pressure and half did not. What was interesting was to look at 5 studies of these 11 that compared macronutrients. And all of them, regardless of the macronutrient percentages, reported similar weight changes. And so you can see there's a high monounsaturated versus high carb, low carb versus low fat, and high protein versus high carb. Again, 8 of these weight loss interventions reported non-significant changes in A1C from baseline at 1 year, and 2, which were in one study, a high protein and a high carb intervention, reported a modest improvement. We should, though, mention the intensive lifestyle intervention in the look-ahead trial, because the question they were asking, would weight reduction reduce cardiovascular disease morbidity and mortality? And as you're probably aware, the trial was stopped early. But it was a very large trial. It enrolled over 5,000 subjects in 16 centers. And you can see that the weight loss were impressive, as well as was the effect on A1C level. I should also mention that, again, we talked about physical activity also being important in this study, but these individuals also were relatively new in their diagnosis of diabetes. As I said, the trial was stopped because it wasn't on track to lead to greater decreases in cardiovascular events. And at the end, the individuals in the intensive lifestyle intervention had lost 6% of their weight, which was very good, versus 3.5% in the control, which was the diabetes support and education group. And you can see the improvements in A1C as well. So what can we say about weight loss interventions in diabetes? Well, as I pointed out, both the intensive lifestyle intervention and the Mediterranean, both including physical activity and individuals relatively newly diagnosed, they were the 2 that have reported improvements in A1C, lipids, and blood pressure, where all of the others reported rather minimal, if any, beneficial results. So what appears is that a weight loss of at least 6 kilograms or 7 to 8% of baseline weight is really necessary for weight loss to benefit people with type 2 diabetes, as well as regular physical activity and support. And how to really implement this, I think, in clinical practice is unknown today. So the question comes up, why doesn't weight loss always lead to improved glycemia? And here are just 3 theories. The first thing that we can suggest is that, as you can see, our usual weight loss therapies are perhaps not intense or adequate enough to lead to adequate weight loss. Or perhaps we're intervening too late. We're intervening when individuals are primarily insulin deficient. And perhaps what we often find even then is that they may lose weight too easily. When weight loss is effective is when people have pre-diabetes and early in the course of the disease. And then I think, and a very important point though, what probably really is important is the energy restriction. that's what leads to improved glycemia. But it may not always lead to weight loss. But what is important is how much people eat. Very easy to say, isn't it? But often people need some help and guidance as to how to do that. So let's change gears and focus for a minute on macronutrients. And this is from the recent Diabetes Association nutrition recommendations. And their conclusion, first of all, was that there's no effective mix of carbohydrate, protein, or fat, and that macronutrient percentages need to be individualized to meet the goals and preferences of the person with diabetes. However, they do mention that monitoring carbohydrate, either by carbohydrate counting, choices, or experience-based estimation, remains a key strategy in achieving glycemic control. Now, I put this next slide in just to remind us that all three nutrients require insulin to be metabolized correctly. I think we often focus so much on carbohydrate and insulin that we forget that the body cannot use protein or fat correctly without insulin either. And so what we see is that insulin is needed for the transport of carbohydrates. We are well aware of that into muscle, adipose, and cells. It also is necessary for transport of amino acids. And we know that insulin activates lipoprotein lipase, which facilitates the transport of triglycerides into the fat cells, which is why often when people are in poor control of their diabetes, they have elevated triglyceride levels. We also know that insulin is needed for anabolic processes, storage. And we know that insulin is needed for glucose to be stored as glycogen. We also know that it's needed for protein synthesis. That's why children don't grow if they're in poor control of their diabetes. That's why adults don't heal. And it's also needed for it also stimulates lipogenesis. Then insulin also prevents breakdown. It prevents the breakdown of glucose from glycogen in the liver. It prevents the breakdown of protein as well as lipolysis. So all three nutrients require insulin. And what has been shown is that about 50% of our insulin needs are for basal requirements and about 50% for bolus. And the bolus covers the meal, and so I think then we need to assume that the basal covers the need for fat and protein. So what we see is that, and it's been shown, is that the bolus covers the need for protein in the meal, and that's about half of the requirement, and that, I think, then leads us to conclude that the basal insulin covers the need for protein or fat. And this is just a study where they documented the fact that it was carbohydrate that determined the need for the amount of bolus insulin needed. And here they asked the question, does the amount of carbohydrate make a difference? And the answer was no, as long as it was covered appropriately. And they found that individuals in the study needed about 1.5 units of insulin for every 10 grams of carbohydrate they ate at breakfast, and about 1 unit for every 10 grams of carbohydrate that they ate at lunch or dinner. So often we do begin with about 1 unit for 15 grams of carbohydrate and then titrate up as needed. And they also looked at other variations such as glycemic index, fiber, or caloric intake, and reported that the bolus dose was primarily determined then by the total amount of carbohydrate the person was planning to eat. Now, we need to be reminded that in this study they kept protein and fat the same. So in this next study, what they did then was to keep the carbohydrate the same, but they added extra fat. And here they added an extra 5 grams of fat to the dinner. and the individuals were on a physiologic insulin delivery algorithm, and they found that when they added that extra grams of fat, the high-fat meal needed about 4 extra units of insulin. And despite that extra amount of insulin, if you see the top of the figure, you can see that the postprandial blood glucose response was still slightly higher from the high-fat meal. But another point I should make at looking at this is that you'll notice that the addition of the fat only affected the post-meal after the meal. It did not affect glucose and insulin levels overnight or at breakfast. And so we often, and I'm sure those in clinical practice have found that when individuals are eating much larger amounts of either fat or protein, they often do need some extra insulin, and basically they're probably doing is supplementing their basal dose. Now, most of the time people keep their protein and fat fairly similar. Just a minute on the glycemic index. I want to point out a common error that I hear, and that is that people are told that the glycemic index tells them how rapidly the carbohydrate is broken down, and that it and people then assume that a high glycemic index food causes a sharp increase in blood glucose levels, and a low glycemic index causes a much slower rise in blood glucose levels. I will say there's no evidence for this claim given in this particular book. Well, this was a study done by Jenny Brand Miller where she looked at the shape of the glycemic index. And you'll remember that the glycemic index does not tell people how rapidly their blood glucose level increases. The glycemic index measures the glucose area under the curve. And so here in the first panel, the green line is 50 grams of 50 grams of glucose. And then the 3 other lines are a high, medium, or low glycemic index breads. And you'll notice the shapes of the curves are the same, and the peak occurs at the same time. You'll also notice that there is a slight difference in the high versus the low glycemic index breads, but the shape of the curve is the same. The second panel, again, the green line is glucose, 50 grams, and the 2 bottom lines are 50 grams of available carbohydrates from fruit juice and fruit, and again, you'll see the lines are the same. And this was her conclusion. There's no statistical difference in the glucose response curve from different foods. Low GI foods do not produce a slower rise in blood glucose, nor do they produce an extended, sustained glucose response, which is what people with diabetes are often told. So the American Diabetes Association had a systematic macronutrient review, and their summary, first of all, looking at the GI, was that there's little difference in glycemic control or glycemic risk factors between low and high GI diets. There was some slight improvement from lower GI diets, but they were generally confounded by a higher fiber intake. The other thing I think it's important for us to be familiar with is that most people do not eat a high or a low carbohydrate diet, most people with diabetes. So what's been shown is that most people with both type 1 and type 2 diabetes eat about 45% of their calories from carbohydrate. That's really difficult to change the percentages. And so what perhaps is important then is that we need to advise healthful carbohydrate choices in appropriate amounts and portion sizes. I want one word about fiber, because again, I often hear that fiber will improve glucose. And what the studies have shown is that it takes over 50 grams of fiber daily for an extended period of time to have beneficial effects on glucose. Now, you're probably aware that average intake is about 20 grams per day. So this is a very, very high fiber diet. The evidence is better for the beneficial effects of fiber, particularly soluble fiber on lipids. But fiber is an important component in healthful eating. And so our recommendations for people with diabetes are the same as for the general public. So our focus is on can be on carbohydrate. It can be useful for all purposes. Persons with diabetes, it emphasizes the total amount, and it divides basically food into three groups: carbohydrate, protein, meat, and fat, meat and meat substitutes, and fat. And you're familiar with the carbohydrate sources, and one carbohydrate serving is based on 15 grams of carbohydrate. And oftentimes we start with 3 to 4 servings per meal of carbohydrate for women and 4 to 5 for men. Ask them to eat consistently and test their blood glucose levels. Get feedback from them on if this is being helpful, and are these reasonable things for them to do. So to summarize what's important with carbohydrate, I think you'd all agree with me that foods containing carbohydrate are important component of a healthy diet, and people with diabetes certainly deserve the right to eat healthfully. No ideal percentages. Monitoring carbohydrate can be helpful, and we need to negotiate with patients as what they are willing and able to do. Just a few minutes on the other macronutrients. We'll start with protein. What we've learned about protein is that ingested protein does not increase plasma glucose levels, even though about 50 to 60% undergoes gluconeogenesis in the liver. The glucose that's produced from protein does not enter into the general circulation, and it's thought that it is stored in the liver as glycogen. But it does increase insulin. And what has been shown is that gram for gram, protein and insulin stimulate the same amount of insulin, telling us that both require equal amounts of insulin to be metabolized. So the recommendations are that protein shouldn't be used to treat hypoglycemia. It's not going to improve, it's not going to have glucose to raise blood glucose levels, and if individuals have type 2 diabetes and can still produce insulin, you don't want protein stimulating insulin production, nor should it be used to prevent overnight hypoglycemia. One other recommendation that changed is the bottom one on this slide, and that is that in persons with diabetic kidney disease, previous studies had shown that reducing protein decreased albuminuria. But as you know, our focus really today is more on glomerular filtrate rate. And the studies have not shown that reducing protein has a beneficial effect on the glomerular filtration rate. And so reducing protein is no longer recommended for persons with diabetic kidney disease. This is just an old study, just to show you some studies done on protein. They gave individuals 50 grams of carbohydrate or 50 grams of protein, or combined the two. In the first panel, the pink line is the glucose response from protein, the green line is from carbohydrate, and the yellow line, which is parallel to that, is from when they combined the two. And then the second panel is the insulin response, and you can see that that carbohydrate and protein stimulate a similar amount of insulin. When combined, it's double. In this slide, they measured the amount of protein that appeared in the general circulation after ingesting 50 grams of protein compared to water. And you can see in the first panel that no glucose, very minimal, appeared in the general circulation. It was a potent stimulant of insulin. And then a word on fat. What animal and observational studies have shown is that higher intakes of fat contribute to greater insulin resistance. In clinical trials, saturated and trans fats have been shown to cause insulin resistance, whereas our monos, polys, and omega-3s do not. And why this may be important is that when people cut back on carbohydrate, what they usually eat more of is fat. And unfortunately, what they often eat more of are saturated fats. And the evidence suggests that this may actually contribute to insulin resistance. It appears hard for people to increase the protein in their diet by much. So if we're going to prioritize our messages to people with diabetes, what would the suggestion be? Well, I would suggest that we think about it as we sit down with individuals, that we remind them that what we're concerned about is what are the changes, lifestyle changes, that they will be willing and able to make that will improve their blood glucose, lipid, and blood pressure control. We've said that for some people, reduced energy intake. For others, or maybe for all people with diabetes, understanding carbohydrate can be beneficial as well. Certainly, we don't want to forget the importance of physical activity. But I think we also need to emphasize the importance of monitoring data, keeping food and blood glucose records to see if goals are being achieved. Because if they're not being achieved, then obviously the management plan needs to be changed. So if we ask the question, what's the best nutrition therapy intervention for diabetes? Well, I would conclude that in an ideal world, people with type 2 diabetes would all lose 5 to 10% of their baseline weight. They would all eat a nutrient-dense eating pattern in appropriate portion sizes. They would all participate in 150 minutes per week of regular physical activity. That all people with type 1 diabetes would count carbohydrates, adjust insulin based on insulin to carbohydrate ratios, and use correction factors. But I think you'd agree with me that none of us really live in an ideal world. So what about in the real world? What is important?
I don't need any more.
I think what is important for us as clinicians and educators is to work with individuals with diabetes to facilitate behavioral changes that they are willing and able to make. They have to tell us what they are going to be able to do. But I would also like to emphasize that I think the suggestions that we give them should be based on proven lifestyle interventions and not on theories. And I hope that what you remember, we started by saying that there are a variety of nutrition therapies that can be implemented, and it's then important to select what will work for the individuals with diabetes that we are educating or treating. But I hope I've also convinced you that lifestyle interventions for diabetes are effective. And these are just a list of some of the references that I mentioned to you, and you can get them. And so at this point, then, I'll turn it back to Dr. Rippey.
Thank you, Marion, for a very interesting and comprehensive review of nutritional therapy for diabetes. We have multiple questions. I'm going to start them in the order that they came in. I should mention to our audience that if your question for some reason does not get answered, Marion has graciously agreed that she will answer them via email on our website. So all questions will be answered. So, Marion, I'll start with this. What is a simplified meal plan?
A simplified meal plan for many individuals is just outlining what individuals should eat at each meal. So, for instance, we might interview a person first to see what their usual food intake is, and then put it down and for breakfast into a simplified pattern. So, for instance, we might say at breakfast have a serving of fruit, perhaps 1 or 2 servings of starches, whatever. And at lunch you might have something like a sandwich or a cup of a hot dish or a soup or something. At dinner you would have like 3 ounces of meat and a couple starches or some fruit or that type of thing. So just a very simple outline based on their usual way of eating. Again, emphasizing, I think, the importance of watching portion sizes.
Thank you. Next question. Could you define what you mean by meal replacements?
Yes, in their studies where they use meal replacements, they use either liquid meal replacements or they use frozen meals. So they were calorie-controlled meal replacements, and they were either a liquid replacement or a prepackaged meal.
Thank you. What is your opinion about patients being instructed to avoid simple sugars?
Well, the research clearly shows that what matters is not the type of carbohydrate, but the total amount of carbohydrate. Now, I always say to all health professionals that I would guess that everyone listening to this occasionally enjoys something sweet. And why would we think people with diabetes would be any different? And so what we have learned is that if it's their choice to have something sweet, they can substitute it for other carbohydrates in their meal plan or in their eating pattern. And of course, the recommendation for them is the same for all of us. We need to be careful of those portion sizes, and obviously there are better choices from the standpoint of healthful food choices, but I think we need to help people with diabetes be able to incorporate occasional sweets into their meal plans safely, and which I think all of us occasionally enjoy doing.
Thank you. Would you say that a person who becomes diabetic and needs insulin will never be able to lose enough weight and eat a very low carb, low calorie diet to come off of insulin?
When they've done those studies, what they have shown generally is that on the low carb diet, they generally will lose weight, more weight at 6 months than perhaps on a low fat diet. But if you follow them out to a year, the weight loss is about the same. And the other problem with those, if you look at those studies, is that their dropout rate is usually higher than other weight loss studies, which suggests that this is something that's difficult for many people with diabetes to do. I think basically what we've learned about diabetes is that it is a disease of insulin deficiency. And like I say, we hope people with diabetes live so long that when they reach that point, when their pancreas is exhausted and can no longer produce adequate insulin, they will need insulin by injection. And it's something I think as educators, I think people with diabetes, unfortunately, are made to feel guilty if they need insulin. And I think we need to better educate them as to what happens in the disease process and that this may be just normal progression of the disease and its management.
Thank you. After a year of maintaining weight loss, does the RMR increase or does it remain low as a continued adaptive measure?
Yes, that's a very interesting question, and you know the answer is unknown. The studies have only been out to a year at this point. So, it's a relatively recently published study, published in 2013, showing it extended for a year. So, hopefully, they're continuing the study, and we'll have that answer for us in the future.
Thank you. Based on your experience, is there a recommended frequency for RD visits in counseling individuals with diabetes? The Academy of Nutrition and Dietetics has made some recommendations for initial diagnosis.
initial interventions. And generally, I think it's helpful if you can have 3 sessions initially. The first session being really an assessment and a negotiation of a proposed intervention, and then a second session where perhaps in 4 to 6 weeks, where the individual comes back with some food records and blood glucose monitoring records, so we can see how things are going, and then perhaps a third one. Again, follow up to see if there were some changes made in the second one, how things are going. Then I think it's very important, and I know not often done, but I think that they need some type of intervention at least once a year. It's so easy to forget about these things that it's just sort of a reminder that this is important, and hey, you're doing great. If they're having problems, how can we help people get back on the right track?
Thank you. Next question. Are you familiar with glycemic load? How does
Yes.
that factor into this discussion?
Right. The glycemic load is primarily used in research. And what the glycemic load does is that you have to take the glycemic index of the foods, and then you have to take the total amount of carbohydrate eaten in that meal and multiply it by the glycemic index, and that gives you the glycemic load. Now, obviously, that's not something people are likely to be able to do in clinically or in the real world, but where it's used is usually when in research studies, when they go back and they can determine the glycemic load in food records.
Thank you. Next question. I am still confused by glycemic index. How do we explain this concept to patients?
Well, I'm not sure you need to, but at any rate, they hear so much about it that I know you have to. So what the glycemic index really does is it measures the glucose response curve after eating 50 grams of available carbohydrate compared to 50 grams of glucose. So 50 grams of glucose is always will be the biggest response, and then the glycemic index compares 50 grams of available carbohydrate from some type of test food, and it compares it to the glucose response with a percentage. But as I pointed out, the shape of the curve is the same.
Next question. Is there more than one research article that indicates low and high glycemic index foods have the same blood glucose levels? I'm sorry. High and low glycemic index foods do not have the same glucose response levels. Our foods that have a higher glycemic response, and there are foods that have a lower. But in the systematic review by the American Diabetes Association, often in the foods that were low glycemic index, they were confounded by a higher fiber intake. And so you don't know if their lower glucose response was because of the fiber content or because of the type of carbohydrate. Okay. I'm afraid we're going to have to cut off questions there. We have had an exuberant number of questions. We have almost 70 questions.
Okay.
And,
well, it may take me a while to get to them, but I will try very hard if you send them to me in an email format to respond.
So to our audience, if I'm sorry that we did not get to your question. If you were one of the 60 that remained, but Ms. Franz will answer them on our website, and there are lots of good questions. So please go to our website to take a look. So I want to just put up this next slide to repeat what learners should have been able to glean from today's webinar. I'll let you read that yourself.
your address within 2 days. And today's webinar will be available to download within 2 days at our website. And if you have any questions or concerns, feel free to email me at my address, which everybody should have, astopnik@ripplylifestyle.com, which is the one that everybody had registered to. Thank you.
Thank you, Amy. As I mentioned at the beginning, this is a webinar today was part of the NutriBite webinar series, which delivers a webinar every 2 months. The next one is on nutrition and oral health, what dietitians should know. It's being delivered by Wahida Karmali, who's a doctor of public health and a research scientist and lecturer in dentistry at Columbia University. That webinar will occur on January 16th, 2014, 2 to 3 p.m. Eastern Standard Time, 1 to 2 p.m. Central Standard Time, and registration is available on our website now if you would care to register. Now, I would like to ask one more favor from the participants. First of all, I would like to thank our wonderful presenter, Marion France, for doing such a great job, and I'd like to thank all of our participants for taking time out of your schedule, your valuable time to participate. We would like one final favor, which should take you less than a minute. If you would stay on the line to do a survey about your experience with this webinar, we would very much appreciate it. It helps us not only evaluate the webinars, but determine topics for future webinars. Again, thank you all for participation, and thanks, Marion France, for an outstanding webinar.